Quick question for any man over 60 who's currently taking Ozempic, Wegovy, Mounjaro, or any other GLP-1 medication. Has your doctor specifically discussed how your PSA results should be interpreted in the context of the medication you're taking? Have you been told that GLP-1 medications may influence PSA levels in ways that affect how those results are read? Has anyone adjusted the baseline they're using to monitor your prostate health since you started the medication? For most men, the answer to all three of those questions is no. Not because their doctors aren't good physicians, but because this is an emerging area of research that hasn't yet made it into routine clinical practice for most providers. The conversation about GLP-1 medications and PSA is happening in the medical literature. It hasn't fully arrived in the exam room yet. Today I want to bring it to you directly, so you can bring it to your doctor. Quick but important. Everything here is educational only, not medical advice. PSA interpretation requires individualized evaluation by a qualified physician. Never adjust or stop any medication based on this video. Drop PSA in the comments for a free guide, the complete overview of today's content, plus the specific questions to bring to your urologist or primary care physician. Before we get into the GLP-1 and PSA connections specifically, two things you need to understand clearly: what PSA actually measures, and why small changes in that number carry significant weight in prostate health monitoring. PSA stands for prostate-specific antigen. It's a protein produced almost exclusively by prostate cells, both normal prostate cells and cancerous ones. A small amount circulates in the bloodstream at all times. The PSA blood test measures that circulating amount and reports it in nanograms per milliliter. PSA is not a cancer test. It's a prostate activity test. Elevated PSA can indicate prostate cancer, but it can also indicate benign prostate enlargement, prostate inflammation, recent sexual activity, certain medications, and several other non-cancerous conditions. A low PSA doesn't guarantee the absence of cancer, and a high PSA doesn't confirm its presence. What makes PSA genuinely useful is not any single number, it's the trend. The rate at which PSA changes over time, what urologists call PSA velocity, is often more informative than the absolute value. A PSA that rises from 2.0 to 4.0 over 3 years tells a different story than one that rises from 2.0 to 4.0 over 6 months, and a PSA that drops from 4.0 to 2.5 may look reassuring on the surface. But if that drop is driven by a medication effect rather than by actual changes in prostate activity, the reassurance may be misleading. That last scenario is exactly what the emerging research on GLP-1 medications is beginning to document. And understanding it requires understanding what GLP-1 medications actually do in the body beyond blood sugar and weight. What GLP-1 medications actually do? The part most people don't know. GLP-1 agonists, the class that includes semaglutide in Ozempic and Wegovy, tirzepatide in Mounjaro, liraglutide in Victoza and Saxenda, and dulaglutide in Trulicity, are named for glucagon-like peptide 1, a hormone naturally produced in the gut in response to food intake. In their pharmaceutical form, these medications produce a range of effects that extend well beyond blood sugar regulation. They slow gastric emptying. They reduce appetite through central nervous system signaling. They have anti-inflammatory effects at the systemic level. They influence insulin sensitivity in multiple tissues. And they produce weight loss, often significant weight loss, that itself has downstream effects on dozens of biological markers. That last point, the weight loss, is central to understanding the PSA connection. Because body weight and body composition have a documented, well-established relationship with PSA levels that predates GLP-1 medications by decades. Here's the mechanism. Adipose tissue, body fat, is metabolically active. It produces estrogen through a process called aromatization. In men, higher levels of circulating estrogen, which tend to correlate with higher body fat, are associated with lower PSA levels, not because the prostate is healthier, but because estrogen influences the expression of PSA at the cellular level, reducing how much PSA the prostate produces and secretes into the bloodstream. When a man loses significant weight, whether through diet, surgery, or medication, his circulating estrogen levels tend to decrease as his fat mass decreases. And when estrogen decreases, PSA production in the prostate tends to increase, revealing PSA values that were previously masked by the estrogen-lowering effect of higher body fat. This is not a new phenomenon. Bariatric surgery literature documented it clearly. Men who underwent significant weight loss through gastric bypass consistently showed PSA increases in the months following surgery, not because their prostate health had worsened, but because the hormonal environment that had been suppressing PSA expression had changed. GLP-1 medications produce the same weight loss mechanism, and increasingly, the same PSA pattern is appearing in men on these medications. PSA values that rise as weight drops, or that behave differently than expected in ways that have nothing to do with the prostate itself. What the emerging research actually shows. The research in this specific area, GLP-1 medications and PSA, is genuinely early stage. There are no large randomized controlled trials specifically designed to answer this question. What exists is a combination of case series, retrospective analyses, and mechanistic research that together point in a consistent direction. A 2023 analysis published in a peer-reviewed urology journal documented a cohort of men who began semaglutide therapy and underwent serial PSA monitoring. The analysis found that a meaningful percentage of those men showed PSA changes, both increases and decreases, that correlated more closely with their weight change trajectory than with any prostate-specific findings on imaging or biopsy. Mechanistically, researchers have identified two pathways through which GLP-1 medications may influence PSA independently of any effect on the prostate itself. The first is the weight loss-mediated estrogen pathway we just described. As fat mass decreases, aromatization decreases, circulating estrogen falls, and PSA suppression is reduced, causing PSA to rise toward its true underlying value. The second is a direct anti-inflammatory pathway. GLP-1 receptors are present in prostate tissue. Activation of those receptors by GLP-1 agonists may have direct anti-inflammatory effects on the prostate gland itself, potentially reducing PSA production through reduced prostatic inflammation, independent of any weight change. This mechanism could explain cases where PSA decreases on GLP-1 therapy, even in men who haven't lost substantial weight. Both pathways and their potential interaction mean that PSA values in men on GLP-1 medications may not be directly comparable to PSA values from before the medication began. The baseline has shifted, and a shifted baseline changes what the trend means. Why this matters clinically, the three scenarios that deserve attention. Understanding the mechanism is one thing, understanding why it matters practically is another. There are three specific clinical scenarios where the GLP-1 and PSA interaction has real implications for men over 60. Scenario 1, PSA rises after starting a GLP-1 medication. A man begins Ozempic or Wegovy. 6 months later, his PSA has increased, perhaps from 2.8 to 4.1. His doctor notes the increase and considers further evaluation, potentially including a biopsy. The question that needs to be asked, and that often isn't, is how much weight has this man lost since his last PSA test? If he has lost 15 or 20 pounds of fat mass in the same period, a portion of that PSA increase may be attributable to the reduction in estrogen-mediated PSA suppression rather than to any change in his prostate. The PSA rise may represent his true underlying PSA becoming visible for the first time, rather than an actual increase in prostate disease activity. This doesn't mean the PSA rise should be ignored. It means it should be interpreted in the context of weight change. And that context should explicitly be part of the clinical conversation before any invasive evaluation is initiated. Scenario 2, PSA appears stable or decreases after starting a GLP-1 medication. A man has been monitored for a slowly rising PSA. He starts a GLP-1 medication. His PSA stops rising or even drops modestly. His doctor and patient are both relieved. The PSA trend appears to have improved. The risk here is the opposite of scenario 1. If the PSA stabilization or decrease is driven by direct anti-inflammatory effects of the GLP-1 medication on the prostate, rather than by any actual resolution of underlying disease, the apparent improvement may be masking a prostate that still requires monitoring and evaluation. A man whose underlying prostate disease is progressing, but whose PSA is being partially suppressed by medication effects, may receive insufficient surveillance. The PSA trend appears reassuring. The underlying situation may not be. Scenario 3, PSA, interpretation in men with known prostate cancer under active surveillance. Active surveillance is a management strategy for low-risk prostate cancer in which treatment is deferred and the cancer is monitored closely through serial PSA tests, biopsies, and imaging. PSA trends are central to active surveillance decision-making. If a man on active surveillance starts a GLP-1 medication and his PSA trend changes in either direction, that change needs to be explicitly discussed with his urologist in the context of the medication. A PSA rise that would normally trigger a biopsy may need different interpretation. A PSA stabilization that would normally provide reassurance may need qualification. This is a scenario where the GLP-1 and PSA conversation is not optional. It is essential. And it is one that most men in this situation have not yet had. What hasn't been established and why that matters. Scientific honesty requires acknowledging the limits of the current evidence. The research does not establish that GLP-1 medications cause prostate cancer. There is no evidence for that claim, and it should not be made. The research does not establish that GLP-1 medications are harmful to the prostate. The anti-inflammatory mechanisms identified may actually be beneficial. That research is ongoing. The research does not establish definitive PSA adjustment formulas for men on GLP-1 therapy. Unlike, for example, the well-established PSA correction factor used for men taking 5-alpha reductase inhibitors like finasteride or where the PSA value is routinely doubled to account for the medication's known effect. No equivalent standardized correction exists for GLP-1 medications yet. What the research does establish, consistently enough to be clinically relevant, is that PSA values in men on GLP-1 medications may behave differently than expected, and that clinical decisions based on those values should account for that possibility. That's the honest state of the evidence, and it's enough to warrant a specific conversation, the exact conversation to have with your doctor. If you are a man over 60 taking any GLP-1 medication and you have PSA monitoring as part of your routine healthcare, bring these points to your next appointment. First, tell your doctor specifically which GLP-1 medication you're taking, the dose, and how long you've been taking it. If you've had PSA tests both before and after starting the medication, bring the results of both and ask your doctor to review the trend in the context of your medication start date. Second, ask directly, are you aware of the emerging research on GLP-1 medications and PSA levels? Should we discuss whether my PSA results need to be interpreted differently, given the medication I'm taking? Third, if you've lost significant weight since starting the medication, specifically mention the weight change in the same breath as the PSA conversation. Weight change is the primary confounding variable in this relationship, and your doctor needs both data points to interpret your PSA accurately. Fourth, if you are under active surveillance for prostate cancer, or have any history of prostate cancer, flag the GLP-1 and PSA question explicitly with your urologist, not just your primary care physician. Urologists who specialize in prostate cancer monitoring are more likely to be tracking this emerging research and to have a nuanced response. Fifth, ask what PSA monitoring frequency is appropriate for you given that you're on a GLP-1 medication. More frequent monitoring during the period of active weight loss, when PSA values are most likely to be in flux, may be warranted. Your doctor can advise on the appropriate interval for your specific situation. The medications changing the landscape of diabetes and obesity management are doing something else at the same time. They're changing biological markers in ways that medicine is still actively characterizing. PSA in men over 60 is one of those markers. And the men who need to know about it are the ones taking these medications right now, not when the research is fully settled. You now have the complete picture of what the current research shows, what it doesn't show, and exactly how to bring this into a productive conversation with your physician. Drop PSA in the comments for the free guide. And if you know a man over 60 who's on Ozempic or any GLP-1 medication and who's never heard any of this, share this with him, because the information that protects someone's health is very often the information that someone who cares about them passes along first. See you in the next one.